Okay, let's set the scene. You're on call. A new patient comes in, acute ischemic stroke, and you see atrial fibrillation on the monitor. The clock is ticking. What do you do?
Exactly. Do you start that anticoagulant right now and risk a devastating brain bleed? Or do you wait, knowing every single hour of delay increases their risk of another stroke? It's the ultimate clinician's tightrope.
Well, today we are explaining the landmark 2025 Catalyst collaboration published in The Lancet. This paper, it finally gives us the answer. And just so you know, all the links to the bibliography are right there in the description below.
So let's get right into that first core question. For a patient with AFib and a new ischemic stroke, if you started DOAC within 48 hours, are you really increasing their risk of a catastrophic brain bleed? For years, this very fear has defined our approach, is that hesitation at the bedside, because the stakes just feel so incredibly high.
Right. And here's the other side of that exact same coin. By waiting that traditional 7 to 14 days, how many preventable recurrent strokes might be happening in that super high-risk early window? I mean, we all know this early period is a minefield for recurrence. Every single day we choose to wait is a gamble.
And that's why we call it the clinician's tightrope. It's this constant, nerve-wracking balancing act between clot and bleed. Anyone who manages stroke patients knows this feeling all too well.
Yep. On one hand, you have this urgent, pressing need to stop another clot from traveling to the brain. But on the other hand, there's this profound, deep-seated fear of turning an ischemic infarct into a hemorrhagic catastrophe. It's the central conflict.
And what's crazy is that for the longest time, we've been walking this tightrope, blindfolded. This has literally been a data-free zone. The huge, pivotal DOAC trials we all rely on, they specifically excluded these exact patients, the ones in the acute phase of a stroke. So we were left with a culture of caution and delay that was based more on tradition than on any hard evidence.
Okay, but that all changes now. The Catalyst collaboration finally gives us the answer we've been looking for. And it's not just a single snapshot from one study. Think of it more like a high-resolution, panoramic view of the entire evidence landscape.
Yeah, and the numbers here are just massive. We're talking about an individual patient data meta-analysis. They combine data from over 5,400 patients. By pooling all that patient-level data, it gives the analysis immense statistical power, way more than any single trial could ever have. We can finally see the true effect with real clarity.
So what did they pool? They brought together the data from 4 of the most important recent randomized controlled trials in this space: Timing, ELIN, Optimus, and START. By putting them all together, Catalyst creates this one definitive dataset to finally answer the timing question.
All right, let's get to the verdict. What did they actually find? Catalyst compared 2 really straightforward strategies. An early initiation group, that means starting a DOAC within 4 days of the stroke, versus a later initiation group, which was 5 days or more.
Okay, so the primary outcome they looked at was a composite, a mix of recurrent stroke or symptomatic brain bleed at 30 days. And the result? Well, it was incredibly clear. The event rate was significantly lower in that early group, coming in at 2.1% versus 3.0% for the later group. That works out to an odds ratio of 0.70. That's a 30% relative risk reduction. Just wow.
And check this out. This is what was driving that benefit. The reduction was almost entirely from preventing more clots. The rate of recurrent ischemic stroke just plummeted from 2.6% in the late group down to 1.7% in the early group. So starting early directly prevented the very thing we are most afraid of.
Okay, but that brings us right back to the elephant in the room, right? The fear that has driven all these delays for decades, the bleeding risk. We have to know, did this incredible benefit come at the cost of more hemorrhages?
And the answer is a resounding, emphatic no. Absolutely not. The risk of symptomatic intracerebral hemorrhage was identical between the 2 groups, 0.4% in both. This is the key. Early initiation gave all the benefit of preventing strokes without, and this is huge, without increasing this most feared complication. This is the reassurance clinicians have been waiting for.
So the big question is, what do we do with this? How do we take this incredibly powerful data and put it into action on our next shift? Let's talk about what this means for the very next patient you see.
It really boils down to 3 clear, practice-changing takeaways. First, initiate early. For the vast majority of your patients, the new goal should be starting a DOAC within 4 days. Second, trust the safety data. That fear of causing a bleed by starting early is just not supported by this incredibly robust evidence. And third, apply this broadly.
The benefit was consistent across a huge range of stroke severities, and even in patients who got thrombolysis or a thrombectomy.
And look, to make this super easy to remember and share with your colleagues and your team, we've got a simple talking point for you. For AFib stroke, don't wait. Early anticoagulate. That's it. It captures the entire essence of the Catalyst findings in one simple, memorable line. So, to sum it all up, the Catalyst collaboration gives us the high-quality, definitive evidence we've been missing for so long. It resolves that core clinical dilemma. The burden of proof has now completely shifted. It no longer rests on those of us who want to start treatment early. It's now on anyone who would still choose to delay.
And that really is the call to action here. This isn't just some interesting academic finding, this is truly practice-changing evidence. So the real question for all of us is right there on the slide. How are you going to change your practice for your very next patient with AFib and an acute ischemic stroke?
The disclaimer and bibliography are in the description.
Thanks for joining us.